Welcome to the deep dive. Today, we're cracking open something fundamental, yet, well, incredibly complex. How your bones actually fix themselves after a fracture.
Mm,
It feels like it should be simple, snap, then mend, but there's just a whole universe of biology at work underneath.
absolutely. A broken bone triggers really one of the body's most sophisticated repair jobs.
Yeah.
And it's a process that affects millions of people every single year, often with significant consequences beyond just the temporary pain.
It really does. Our source material for this deep dive pulls from some pretty comprehensive scientific reviews on fracture repair and, interestingly, the really critical role of inflammation in that
Yes,
process.
that's key.
So our mission today, to guide you through the intricate biological steps of bone healing, uncover the hidden factors that can either help or seriously hinder it, and maybe look at ways we might be able to lend the body a hand.
A shortcut.
Exactly. This is your shortcut to truly understanding what happens when bone breaks.
And as you touched on, the stakes are, well, they're high. Fractures don't just cost money, they profoundly impact lives, mobility, independence.
Hmm.
You consider something as common as a hip fracture. In older adults, tragically, nearly 1 in 3 patients over 50 don't actually survive within a year of that injury.
Gosh, that's stark.
So better understanding healing isn't just academic, it's vital for improving outcomes. Really vital.
Okay, right. Let's unpack this then. Before we see how bone heals, maybe let's just talk briefly about what it is. We tend to think of bone as just solid, but it's quite dynamic, isn't it?
Oh, very much so. You have two main types. The dense, hard outer layer, called cortical bone, which provides that rigidity.
Right, the shell.
Exactly. And then there's cancellous bone, found inside, which is more spongy. It's made up of a network of little struts and plates we call trabeculae. And these structures handle different kinds of stress, you see. Bones themselves also come in different shapes. You've got long ones like your femur, short ones like in your wrist, flat ones like the skull, and irregular ones like your vertebrae.
And what are they actually built from? I mean, at a microscopic level.
At its core, bone is a composite material. You've got the inorganic part, primarily a mineral called hydroxyapatite, which is basically calcium phosphate. That's what gives bone its hardness.
The mineral bit.
Yes. And the organic part is mostly protein fibers, specifically collagen type I, which provides flexibility and a kind of structural framework, plus other proteins and, crucially, signaling molecules like growth factors.
Right, so it's strong, but it also has that bit of flexibility that
Mhm.
give. Now, the sources mentioned bone modeling and bone remodeling. They sound quite similar, but what's the actual distinction?
Yeah, they're related, but definitely distinct processes, both
Mhm.
constantly happening in healthy bone, mind you.
Yeah.
Bone modeling is about changing the actual shape of the bone in response to the forces placed on it. Think of Wolff's Law.
Wolff's Law.
Yes. Basically, if you stress a bone in a certain way consistently, it will subtly alter its shape or thickness over time to adapt to that stress.
Oh, okay. So if someone starts, say, lifting weights seriously, their bones might actually reshape slightly to cope?
Precisely, yes. Bone remodeling, on the other hand, is more like the body's ongoing maintenance crew for bone.
Right.
It's about replacing old, maybe micro-damaged bone with new bone to keep it strong, maintain the mineral balance in the body, and just ensure overall bone health. This happens in a cycle. Cells get activated, old bone is resorbed,
Dissolved away.
yes, dissolved away by specialized cells called osteoclasts. Then there's a brief reversal phase,
Hmm.
and then new bone is formed by cells called osteoblasts. This renewal creates new structural units within the bone called osteons.
Okay, so modeling is adapting shapes, remodeling is that constant upkeep.
Got it. Now, healing a fracture must be different again from the sort of daily maintenance. Oh, absolutely. Bone healing is a dedicated repair process, specifically triggered by the injury itself. And how it proceeds depends quite a lot on how much the broken ends of the bone can move relative to each other, what we call the level of stability or perhaps strain at the fracture site.
Stability matters that much.
Usually. Massively important.
Mhm.
If the fracture site is held rigidly, meaning very little movement, maybe less than 2% strain between the fragments,
Mhm.
the body can go straight to a direct repair. This is called primary healing.
Ah.
It usually requires surgeons to fix the bone very precisely with implants, like compression plates, that hold everything tightly, really tightly together.
And how does the bone heal without the usual steps if it's held perfectly still like that? Is it faster?
Well, it bypasses the formation of a large external callus, that lump you often see. Instead, the bone's own remodeling units, those cutting cones we mentioned, where osteoclasts tunnel through bone, followed by osteoblasts laying down new bone, they essentially tunnel directly across the fracture line.
Straight across the gap.
Yes, reestablishing the connections and the blood supply directly, it's actually a slower process initially, happening microscopically,
Yeah.
and you don't see that big lump of callus forming on the outside.
That's quite neat, isn't it? So no messy callus, but it needs really tight control.
Yeah.
What's the more common way bone heals then in the, real world?
That would be secondary healing. This happens with what we call relative stability.
Mm-hmm.
So a bit of controlled movement is allowed, maybe between 2% and 10% strain.
Okay.
This is typical for many common treatments like casts or external fixators, or indeed nails placed inside the bone marrow cavity.
And this is where we see those classic stages of healing and that lumpy callus you mentioned earlier.
Exactly. Secondary healing uses two main biological pathways to build new bone tissue. One's called intramembranous ossification, where bone forms directly, and the other is endochondral ossification, where a temporary cartilage structure is formed first and then turned into bone. It unfolds in roughly 4 overlapping stages.
Right, let's walk through those. What's the very first thing that happens right after the break? The immediate aftermath.
The immediate response is the inflammation stage. It starts right away, lasts about 5 days, give or take. When the bone and the surrounding tissues break, blood vessels are torn, creating a large blood clot or a hematoma at the site.
The bruise, essentially.
Yes, but this hematoma is actually critical. It's the foundation, it's the scaffold for everything that follows. It's not just waste material.
So all that bruising and mess is actually necessary. It's doing something important.
Completely. It's packed with cells and molecules that kickstart the repair. The damaged tissues release inflammatory signals. Think of them like chemical distress flares.
Okay.
Things like TNF-alpha, IL-1, IL-6. These attract inflammatory cells, macrophages, monocytes, which have the job of cleaning up debris and dead tissue. And they also release growth factors like VEGF that promote new blood vessel growth into the area. Angiogenesis.
And this is where our sources really highlighted that fascinating, almost sort of paradoxical role of inflammation, didn't they?
Precisely. That initial burst of inflammation is absolutely necessary to initiate secondary healing properly. If you block it completely right at the start, healing gets delayed significantly. Studies show this.
What? There's a but, isn't there?
But here's the twist. Too much inflammation, especially if it's prolonged, or if there's systemic inflammation from, say, a severe infection elsewhere or major trauma, that significantly impairs healing. It disrupts the process.
Which brings us to something many people do almost instinctively. Taking anti-inflammatories like NSAIDs, non-steroidal anti-inflammatory drugs after a fracture, mostly for pain relief. What does the source material say about that practice?
Yeah, this is a really critical point, actually. NSAIDs work by inhibiting enzymes called TYROX enzymes. Now, these are key players in that initial inflammatory cascade, but they're also involved further down the line in bone formation itself.
Oh, right.
So whilst they definitely reduce pain, the evidence from multiple studies is, well, it's concerning. NSAID use has been linked to slower healing rates, higher instances of the bone failing to heal completely, what we call a non-union.
Non-union, right.
And the new bone that does form can actually be weaker. So the takeaway from the sources is that a balanced, tightly controlled inflammatory response is absolutely key for good secondary healing. You need it, but critically, it has to switch off when its initial job is done.
So it's like Goldilocks information needs to be just right. Not too much, not too little, and not for too long. What happens after that crucial inflammatory start then? What's phase 2?
The next phase is repair, where a fibrocartilaginous network, or what we call the soft callus, begins to form. This overlaps with the inflammation starting around day 5 or so.
Okay.
Mesenchymal stem cells, essentially the body's versatile repair cells, are recruited, often for the bone's outer membrane, the periosteum, and the inner line in the endosteum. Signaling molecules, particularly BMPs, bone morphogenetic proteins, tell these stem cells what to become. Some become fibroblasts, which lay down fibrous tissue, and others become chondroblasts, which create cartilage.
So they're building a kind of temporary bridge across the gap.
Exactly that. The fibroblasts create a matrix, and the chondroblasts form this collagen-rich fibrocartilage that spans the fracture gap. This is the soft callus, which provides some initial flexible
stability, right.
Simultaneously, directly from the periosteum, that outer membrane of the bone, some immature bone called woven bone, starts forming as well. And all the while, new blood vessels continue to grow vigorously into the area, guided by factors like VEGF.
And you mentioned movement influences this stage.
Yes. Interestingly, the amount of initial controlled movement influences the size of this soft callus. A bit more relative motion tends to lead to a bigger soft callus, providing more stability for that motion. The tissue forming early here, called granulation tissue, is actually quite tolerant of strain.
Okay, so you've got this flexible cartilage and woven bone scaffold forming. How does that actually turn into solid, strong bone? What's next?
That's the third stage, bony callus formation, or the hard callus stage. This phase kicks off maybe 1 or 2 weeks in, sometimes up to 4, and continues for several weeks. The key process here is that endochondral ossification we mentioned.
Turning cartilage into bone.
Exactly. That temporary cartilage bridge is systematically replaced by bone. Osteoclasts, the resorbing cells, clear away the cartilage framework, and osteoblasts, the building cells, move in right behind them, depositing woven bone.
So the cartilage isn't the final material at all, it's just a template, really.
Precisely. It gets converted.
Right.
And more woven bone is also added directly from the periosteum during this time. Crucial signaling pathways, like the one involving ARANG-KL, are very active here, telling the necessary cells, the osteoclasts and osteoblasts, to differentiate and do their jobs. Good blood supply is still absolutely essential, bringing in more stem cells and nutrients. And this stage benefits from appropriate relative motion at the fracture site, as that seems to encourage the cartilage to bone conversion.
And once you have this hard callus of woven bone, is that the finished product? Is the bone healed then?
Not quite. Not the final product. The final stage is remodeling. This actually begins whilst the bony callus is still forming and continues for months, sometimes even years after the initial injury.
Months or years? Wow.
Yes. The hard callus, which is initially quite bulky and made of disorganized woven bone, is slowly but surely reshaped and strengthened. Osteoclasts resorb the woven bone, and osteoblasts lay down more organized, stronger lamellar bone in its place.
So replacing the temporary, maybe slightly messy bone with the final strong version, tailoring it.
Exactly. This coupled remodeling refines the shape of the bone, making it stronger where it needs to be based on the mechanical stress it experiences, reinforcing Wolff's Law again, you see.
Right.
There's also thought that tiny electrical charges generated when bone is loaded, called piezoelectric charges, might play a role in guiding this remodeling activity. It's a really complex, long-term refinement process, orchestrated by a whole host of different signals.
So the body's not really done with the repair for a long time after the cast comes off then?
Absolutely not. The initial healing to a point where the bone is stable might take weeks or months, depending on the fracture and the person, but the bone continues to optimize its internal structure and strength for a year or even more.
Okay. Beyond the biology of these stages, what are the biggest factors that can make a bone heal well, or conversely, really struggle to mend?
Oh, there are many. And it's helpful to think about factors specific to the injury site, local factors, and those relating to the person's overall health systemic factors.
Right. Local first.
Locally, probably the absolute most important factor is blood supply. A fracture inevitably disrupts the blood vessels in and around the bone. Good blood flow is like the supply chain for healing, bringing in the cells, oxygen, nutrients.
Makes sense.
While supply is reduced right at the start, it actually peaks dramatically around 2 weeks post-injury, before eventually normalizing months later. Anything that compromises this blood supply, like a very severe injury-crushing vessels or even certain surgical techniques, if not done carefully, significantly increases the risk of delayed healing, or that non-union we mentioned.
What about the nature of the break itself? Does the type of fracture matter?
Oh yes, definitely. Mechanical issues are key. Excessive movement, if the fixation isn't stable enough for the healing type, bones not being lined up properly, malalignment, extensive damage to the surrounding muscles and soft tissues, actual bone loss at the fracture site, or complicated fracture patterns.
Like when it shatters.
Exactly. Like if the bone shatters into multiple pieces or has large butterfly fragments that have poor blood supply, all these make healing much harder and increase the risk of the bone not knitting back together properly.
And then there's the really serious complication you hear about infection.
Yes, osteomyelitis. A truly dreaded complication in bone healing. It occurs in maybe 1–2% of closed fractures, but the risk jumps dramatically, up to maybe 30% or even higher in some series, in open fractures where the bone breaks through the skin.
And why is infection so bad for healing?
Infection completely derails the normal healing process. Instead of forming that crucial woven bone callus, the body tends to form fibrous tissue in response to the bacteria. It massively reduces the mechanical stability, prevents proper union, and can lead to chronic pain, long-term disability, limb loss in severe cases, even sepsis.
Gosh. How do doctors even spot and treat a bone infection? It sounds deep-seated.
It can be tricky, yes. It might present with general symptoms like increasing pain at the fracture site, maybe fever, chills, redness, swelling. Standard blood tests looking for signs of inflammation or infection, like a full blood count, ESR, CRP, can be helpful screens.
And imaging.
Imaging like X-rays might show changes later on, but bone scans or MRI, particularly MRI, are often more accurate for seeing soft tissue involvement and early bone changes. But really the definitive way to diagnose it, the gold standard, is usually a bone biopsy.
Taking a sample.
Yes, taking a sample of the bone tissue to look at under a microscope. And, crucially, to culture any bacteria present, so you know exactly what you're fighting. Treatment, then, is usually quite aggressive. First, you have to control the infection source, which often means surgically removing any infected metalwork, cleaning out dead or infected bone and tissue debridement.
Right.
And then long courses of intravenous antibiotics are typically needed, often for 6 weeks or even longer in adults, usually targeting the most common culprit, which is Staphylococcus aureus. Because blood supply can be poor in infected or damaged bone, it takes a long time for those antibiotics to penetrate and reach effective levels.
Okay, so those are the local challenges. What about the systemic factors, things about the person's overall health?
Exactly, and these play a massive role, often underestimated. Things like advanced age, for instance. Older individuals often have a naturally slower healing capacity, perhaps a less robust immune response, and sometimes a baseline state of increased systemic inflammation that can actually work against efficient healing.
And body weight. Does that play a part?
Obesity has been linked to delayed healing, certainly in animal studies. They show altered levels of important growth factors and increased inflammatory signals that seem to disrupt the normal sequence of repair.
What other conditions are significant?
Other systemic conditions are crucial too. Anemia can affect oxygen delivery to the healing site. Endocrine problems like diabetes mellitus significantly impair healing. Some sources suggest healing can take roughly 1.6 times longer in diabetics.
Wow, that much longer.
Yes, partly due to effects on those stem cells and the process of converting cartilage to bone, and also often associated with poorer circulation. Menopause, due to hormonal changes affecting bone and issues with the parathyroid gland, which regulates calcium, also impact bone metabolism and healing. And long-term steroid administration, often prescribed for other inflammatory conditions, is associated with higher rates of non-union in some fracture types.
Malnutrition seems like an obvious one, perhaps, but are there specific deficiencies that are particularly impactful for bone?
Absolutely. Deficiencies in vitamin D and calcium are strongly linked to non-unions and poor bone health generally. Not getting enough protein can reduce the strength of the callus that forms, and interestingly, even things like previous gastric bypass surgery can affect calcium absorption down the line, making adequate supplementation really critical for those patients if they sustain a fracture.
And smoking. I think most people assume that's bad, but how bad is it for bone healing specifically?
It's a huge factor, really significant, and the numbers are quite stark. Nicotine itself slows down the healing rate. It inhibits angiogenesis, that vital growth of new blood vessels needed for repair, and dramatically increases the risk of non-union.
How much?
Well, one source mentioned a 500% increase in the rate of pseudoarthrosis or non-union in spine fusions for smokers compared to non-smokers. Smokers can take around 70% longer on average to heal challenging breaks like open tibial fractures. And even when it does heal, the bone form tends to be significantly weaker.
That's really quite dramatic. Any other conditions or medications the source is highlighted as being problematic?
Yes. HIB is associated with higher rates of fragility fractures in the first place and also delayed healing. This can be multifactorial, linked perhaps to the antiretroviral medications themselves, sometimes poor circulation, altered inflammatory responses, sometimes a TNF-alpha deficiency has been noted, and potential nutritional issues. And beyond the NSAIDs and steroids we've discussed, some studies suggest that very long-term use of certain bisphosphonate medications used for osteoporosis might be associated with slower healing times or rarely unusual fracture patterns. And certain types of antibiotics, specifically quinolones, have been noted in some research as potentially being toxic to chondrocytes, those cartilage-forming cells crucial for secondary healing.
So it's this incredible interplay then, isn't it, between the injury itself, how we try to stabilize it, and the whole picture of the person's underlying health and habits. That really underlines the importance of those principles surgeons follow, like the AO principles you hear about.
Exactly right. The whole clinical approach is geared towards trying to create the optimal biological and mechanical environment for this complex cascade to succeed. The AO principles, restoring the anatomy as best as possible, reduction, providing the right kind of stability for the healing pathway you want, fixation absolute for primary, relative for secondary, preserving the blood supply during surgery, and getting the patient moving safely as early as possible. They're all aimed at giving the bone's natural healing power the best possible chance.
Given all these potential roadblocks and influencing factors, are there ways we can actively try to stimulate the healing process if it's slow or stalled?
Yes, there are methods used, although it's fair to say the evidence base for some is still evolving and debated. Bone stimulators are perhaps the most well-known. These are devices that apply low-level electrical or electromagnetic fields or even ultrasound waves to the fracture site.
How do they work?
Well, the exact mechanisms aren't always fully understood. Electrical or electromagnetic fields might mimic some of the body's natural signaling or the effects of mechanical loading. Ultrasound, particularly low-intensity pulsed ultrasound, or LEACUs, might increase the activity of chondrocytes and enhance soft callus formation, potentially leading to earlier hard bone.
Is there good evidence for them?
Lithius, for instance, has reported success rates up to 80% in some studies for helping delayed unions or established non-unions to finally heal. There are different types of electrical stimulation too: direct current, capacitive coupling, pulsed electromagnetic fields, each thought to influence different aspects of cell behavior or matrix production. But, as I said, the overall evidence for stimulators is still somewhat mixed across different fracture types and situations, and definitely warrants more high-quality research.
So, technology aside, what else?
Well, beyond devices, ensuring the body simply have the basic raw materials is key. That means robust dietary support, ensuring adequate intake of calcium, protein, and vitamins, particularly vitamin C and vitamin D. And for cases with significant bone loss or established non-unions where simpler methods fail, bone grafting remains a common and often effective technique.
Using bone itself as a scaffold.
Exactly. Using either the patient's own bone, autograft, or donor bone, allograft, as a scaffold to bridge the gap and provide the necessary cells and signals to encourage new bone formation.
This really highlights that fixing a fracture is so much more than just, putting the pieces back together on an X-ray.
It's absolutely a holistic challenge. Achieving the best outcome for a patient with a fracture requires not just surgical skill in the operating theater, but a deep understanding of this intricate biological process and diligent management of all the influencing factors, both local and systemic. It really necessitates an interprofessional team effort. Doctors, specialist nurses, physiotherapists, dietitians, occupational therapists, all working together to support the patient through their recovery. That includes addressing things like nutrition, pushing for smoking cessation, managing diabetes effectively, and ensuring proper follow-up, rehabilitation, and maybe counseling.
This has been a truly fascinating deep dive. It reveals just how complex and, in some ways, how delicate the process of bone healing really is. We've seen it involves distinct stages, different repair types depending on the stability provided, relies critically on that balanced inflammatory response and good blood supply, and is profoundly influenced by everything from the specifics of the injury itself to the patient's overall health, their lifestyle choices, medications, the whole picture.
Understanding these nuances is absolutely key to appreciating why healing isn't always straightforward and why some breaks are just so much harder to fix than others.
So, considering just how much those systemic health factors and lifestyle choices like smoking, diet, conditions like diabetes impact the body's fundamental ability to repair itself after an injury, here's a final thought for you to ponder. How might focusing more deliberately on optimizing overall health before an injury even happens a truly preventative, preemptive health approach? How might that dramatically improve not only fracture outcomes and reduce long-term disability for individuals, but also potentially lessen the significant burden these injuries place on healthcare systems worldwide?
Certainly makes you wonder, doesn't it? If perhaps the biggest future gains in fracture care might actually come from addressing patient health long before they ever step into an emergency room with a broken bone. A paradigm shift.
Absolutely. Definitely something worth mulling over. Perhaps considering your own risk factors, or indeed looking further into the evolving science behind some of those technologies like bone stimulators as more evidence emerges.